Good morning, everyone. Today we will be starting classes, online classes for the pediatrics. I hope you all join it. Okay, we'll start it. Today we will be discussing on the topic, very important one, childhood malnutrition. You all know malnutrition. So to understand malnutrition, you have to know nutrition. What do you mean by nutrition? Nutrition is a process by which the organism utilizes the food. So what are the types of food utilizes? That is energy yielding foods like carbohydrate, for example, rice, sugar, and fats. What are the body building foods? There are protein, which are present abundantly in the milk, in the meat, and all those cereals. And also we need protective foods. These are the vitamins. You have water soluble vitamins, fat soluble vitamins, vitamin A, C, D, and minerals like calcium, iron, etc. So all these food, this is processed by the organism is consumed. So malnutrition, malnutrition in the sense that nutrition is altered. So it can be divided into two groups. One is undernutrition, that is nutrition which is not sufficient for the child, and overnutrition, that is excessive intake, for example, overeating may lead to obesity. Coming to protein energy malnutrition, this is a range of pathological conditions which are arising from the lack of various proportions of foods containing protein, calories, and fats. This is more common in children, especially infants below 1 year, and young children, especially below 5 years. And this child who are suffering from protein energy malnutrition are usually associated with infection. What are theories of malnutrition? Many theories arises. One is protein deficiency. Protein deficiency will lead to malnutrition. And toxic theory. What do you mean by toxic? Toxicity coming from infections, repeated infections, or excessive consumption of the protein can also cause toxicity. So, toxic theory is also there, and another one is niacin theory. That is, particular vitamins like niacin, when there is lack of niacin, can cause many symptoms in the body, especially related with the nervous system, and increased ferritin level. This is ferritin is a acute phase reactant, and this is increase in the body will causes free radicals. So this will act as a hazard to the body, leading to the malnutrition. And one scientist called this pioneer of the pediatrics, that is Gopalan, Dr. Gopalan, he has developed a theory called disadaptation theory. In this theory, malnutrition can be divided into different presentation. One is marasmic type, one is Kwashiorkor type, and maybe acute onset or chronic onset. So acute onset are due to the acute shortage, acute problem in the child, and chronic one is the prolonged malnutrition. So this is developed by the Gopalan, and recently there are two theory, that is free radical theory and aflatoxin poisoning. These are again resulting from some infections which leads to release of the free radicals, and this will cause damage in the cells and leading to the malfunction of the cell, ultimately causing the malnutrition. And aflatoxin, this is the toxin which is present in some cereals, and this can also cause same thing, damage to the cells of the body, which leads to damage in the cell. To know the free radical theory, we have already mentioned that free radicals are releasing substances, and these are toxic to the cell membrane, and they produce during various infections, maybe in the GI tract, maybe in the major space tract. When infection is there, there will be release of the free oxygen radicals, which leads to damage in the cell membrane. And these oxides are normally buffered by the protein, but when protein is lacking or antioxidants like vitamin A, C, E, selenium are lacking, then this will be increased and this will cause more toxic to the cell membrane. So ultimately the child will become malnourished, and uh, there may be damage in the liver cells. And when liver cells are damaged, ultimately the child will develop kwashiorkor type of the malnutrition. This is again visualization showing the malnutrition. There is a cycle of the malnutrition, infection, release of free radicals. So inadequate protective pathway due to the lack of protein, and release of free radical due to the toxins or infections, which is causing macromolecular damage catalyzed by the iron and leading to the inadequate repair of the cell, and it causes fatty liver. So malnutrition will lead to fatty liver. Aflatoxin theory is same thing. When there is low protein diet, growth will ultimately stop, and this will lead to stunting. Stunting means decrease in the height. And very low protein containing foods consumed, then the child may have anorexia, that is loss of appetite, and this will lead to marasmus, that is muscle wasting, sedentary muscle wasting. And insufficient diet will cause weight loss, and this will lead to wasting. The wasting has got different forms of malnutrition, that is marasmic kwashiorkor or kwashiorkor. We'll come to know what is marasmus and what is kwashiorkor later. Then another important is when there is infection, why there is increase in the malnutrition. That is, it involves the immunity. You have got immunity, humoral immunity, cell-mediated immunity. So when there is infection, immunity will be reduced, and this will causes uh, malnutrition, where the immunity and the infection, they are in vicious cycle. When there is infection, there will be low immunity. When there is low immunity, there will be infection. So this will cause protein energy malnutrition. These infections like diarrheal diseases, pneumonia, septicemia, that is infection in the blood, measles, tuberculosis, malaria, urinary tract infections, any sort of infection in the body can have this problem of immunity low in the body. Even the intestinal parasites like Ascariasis, Ankylostomiasis, Giardiasis can also reduce immunity. And those children who had already reduced immunity can also have this parasitosis. So all these uh, immunity functions is reduced during the infection will lead to malnutrition. As I have mentioned, humoral immunity like IgG, IgM, secretory IgA, they are not significantly affected in the mild form or moderate form of malnutrition, but it is depressed in the severe form of malnutrition. And you also have another immunity called cell-mediated immunity, and this is impaired in all forms of malnutrition, grade 1, grade 3, grade 2, etc. And that's why when you want to diagnose tuberculosis, you have to do one test called tuberculin test. And this tuberculin test is negative in a child who is suffering from malnutrition like marasmus and kwashiorkor, because they cannot express the cell-mediated immunity because immunity is down. So, following dietary treatment, patient will improve. Tuberculin test may become positive. Earlier, in the severe form of malnutrition, tuberculin may be negative. After treatment, the child will become alright. Then, if you repeat the tuberculin test, it will become positive. That means it shows that there is improvement in the cell-mediated immunity also. And serum C-reactive protein, complement C3 are depressed in the malnutrition, and this again it is especially present when there is infection, and you do the test for C-reactive protein and complement C3, it will be raised because it is acute phase reactive. Coming to etiology of protein energy malnutrition. You understand that malnutrition and which is related with the protein and the energy yielding foods like carbohydrate and fats. So what are the causes? That is, one is conditioning influences, like the child who is born low birth weight. For example, the child at a normal birth weight is 2.5 kg and above. And if the child is born and the weight is only 1.5 kg, then it is called low birth weight baby. And this low birth weight baby, when they grow up, they will tend to have malnutrition and they tend to have repeated infections. And another factor for causing malnutrition, it is cultural practices. Like different culture have different food habits. Some are vegetarian, some are taking meat, some are not taking meat. And method of cooking, some it's raw, some it's cooked food, like that. So depending upon that, the prevalence of the malnutrition also present in those uh, groups of person where there is lack of balanced food. Another cause is socio-economic factors. You know that poverty, illiteracy, and of course lack of knowledge. Mother may be, or parents may be, or caretaker of the child may be well-to-do, educated, but if they don't have the knowledge of nutritional value of the food, like which food contains protein, which food contains carbohydrate, and they are not acknowledging that one and giving any sort of food, then the child may have developed malnutrition. That is protein energy malnutrition. And last is food production and intake. You know that every child should have breastfed exclusively for 6 months. This is advised by the WHO. If there is abrupt withdrawal of breast milk, the child is supposed to feed up to 6 months exclusively, but due to some reasons, the child has stopped breast milk by 3 months. Then the child may have developed malnutrition. And another one is delayed and inadequate complementary feeding. Complementary feeding means food which is started in addition to the breast milk. A child who is 6 months old should start complementary feeding because exclusive breastfeeding is only up to 6 months. If complementary feeding is started late, for example, by 1.5 years, some mothers they don't give complementary feed by 6 months, so they started at 1.5 years. Then definitely this child will have malnutrition because it's inadequate for him. And another one is lack of supplementation for target group. For example, we are supplementing vitamin A during the immunization session. We are giving vitamin A to the every child who's coming for immunization at 9 months onwards. And we also have program for supplementation of iron in the adolescent groups and of course in the young infants also. If this supplementation is not there, then they may also have some micronutrient deficiency as a protein energy malnutrition. You see this picture, this child. What is the difference in this child? There are two child. This is born by the same mother, twin baby, and this is about 7 months old. And this child on the left side, it is playful, alert, neat, and skins are normal, healthy looking. Whereas other side, the child is having pigmented, hyperpigmented skin lesions, excoriated, scaly skin lesions, and this is edematous, and the child is irritable, crying all the time. And these two children, what is the difference is they have given different food. What food? That is this child, healthy one, he is getting mother's milk, exclusive breastfeeding. And mothers thought that her milk is not sufficient, so she is giving other milk, that is top milk, to this side on the right side. And the top milk, when we ask the history, this is present in our departments in the pediatric ward, admitted for this child. And when we ask the history, mother says that I have not enough milk, so I have given top milk. What top milk? This is powdered milk. And what is a dilution? It was over diluted and frequency was less for the child, and he is not giving any vitamin supplement also. So definitely the difference between exclusive breastfeeding for 6 months and not, there is a difference, and ultimately this child is unlucky because he is suffering from the protein energy malnutrition. Now coming to classification, we have more than 5 classification of malnutrition depending upon the weight of the child, height of the child, and mid-arm circumference, etc. And the most common one is IAP, Indian Academy of Pediatric Classification of Malnutrition. Here we know the age of the child and we know the weight of the child, and there are charts which is printed for expected one. For example, the child 1 year old, the expected weight is about 8 to 10 kg. So the this any child, when we take the weight and check the age of the child, and if it is more than 80% of the expected weight of that age, then he is normal. And grade 1 means 70 to 80% only, grade 2 60 to 70%, 50 to 60% grade 3, and if less than 50% of the expected weight for that age, for example the child is 1 year and her expected weight is 10 kg and she is weighing only 4 kg, then definitely it is less than 50%, and this is having she is having severe form of malnutrition, that is grade 4. Another classification is we know the weight for the age, and we have to look clinically whether the child is having edema. Edema is the collection of fluid in the subcutaneous region, so especially in the feet, pedal edema, and with edema or without edema, we have to check it. And if the weight is 60 to 80%, the child is having underweight when there is no edema. And if the child is less than 60% and no edema, that is called marasmus. And if edema is there and weight is 60 to 80%, we call it kwashiorkor. And if less than 60%, that means severe wasting is there, then we call it marasmic kwashiorkor. So like that, clinically as well as take the anthropometric measurement, weight, height and all, then we can classify the malnutrition. Another one is depending upon the height. We have to check the height of the child. We should know the age of the child. We should see in the appropriate chart. And then if weight for age is different, then there are groups of scientists. One is Waterloo, one is McLaren, one is B Round. There is not much difference, and they have given, according to their study, they have different outcome. That's why they are giving the different readings. So in the Waterloo group, normal means more than 95% of the height of the expected. In the McLaren 93 and B Round is 90. And when height is low, we call it stunting. So if there are 3 degrees, if first degree stunting means weight for the age is 90 to 95 in the Waterloo, and in other is 80 to 90 and 80 to 93 and 80 to 90. And second degree stunting means 85 to 90% expected, and third degree, that means the child is having less than 85% of the expected height for that age, and that is also called dwarf. Another classification, this is again very important because this is a age independent. We don't need to know the age of the child. So we take the weight of the child, we take the height of the child, and there are percentile charts given by the WHO, and also there are this Waterloo and the McLaren. According to Waterloo and the McLaren, weight for height is normal if the child is having more than 90%, and there is mild wasting, first degree wasting, that is 80 to 90%, second degree or moderate wasting, that is 70 to 80%, and severe wasting, that is less than 70%. That means when we see the chart and the child is taking weight and height, and then we look first in the height and then we check on the weight. According to, for example, the child's weight height is 100 centimeter and weight is 8 kg. That is normal for that chart. And if the child actual weight, when we check the weight of the child, that is 4 kg, then definitely weight is low for that height. So that's why we call it for this one weight for height chart. And WHO has given a very nice, and it is called as the ASD score, that is also known as Z score. Now another way of classifying the malnutrition, that is very easy one. You need only one measuring there. You don't need age of the child. And for the this thing normal or not, we can consider the age, but actually we don't need the age of the child for measurement. So any child who is below 5 years, we take the mid arm circumference, because arm length, arm circumference is constant. How to take? We point here in the tip of the acromion process of the clavicle up to the olecranon process of tip, olecranon process, and take the midpoint. So here is the midpoint, and we measure it this circumference, and this circumference will interpret as in normal more than 13.5 centimeter, in mild to moderate malnutrition 13.5 to 12.5 centimeter. If the child's mid-arm circumference is less than 12.5 centimeter irrespective of age, then the child is suffering from severe malnutrition. And this is also a very important one. What are the indicators? We know the malnutrition, or we know the classification, and then how do we know that the child is having stunted, wasted, or underweight? This is a WHO classification. WHO has classified this undernutrition into three groups. So number one is stunting. Stunting means we know that low in the height for the age, and this indicates the chronic malnutrition. Low in the height indicates the chronic malnutrition. And wasting, that is low weight for the height, that it indicates the acute malnutrition. And underweight, here low weight for age. Maybe both weight may be low in acute and chronic. But in the chronic form, you should take the height and then should find out whether it is low. Then if it is low height, then we can know, we can say say that the indicator of the malnutrition is chronic type. Coming to spectrum, what are the presentation, what are the forms of malnutrition? Protein energy malnutrition, we have already seen earlier also with the classification. So what are the form? One is underweight, simply weight is low, and one is kwashiorkor, where edema is present. One is marasmus, where there is no edema but severe wasting is there, and when there is marasmic kwashiorkor edema plus severe wasting will be there. Another term is pre-kwashiorkor. Here the child is likely to develop edema but not yet develop edema. So within 3-4 days the child will develop edema. This is pre-kwashiorkor. And nutritional dwarfism, as we have mentioned, stunting. Here there is no wasting, and this is resulting from micronutrient deficiency like vitamin deficiency, mineral deficiency. And in children between these 6 to 24 months, there are forms of protein energy malnutrition, but they are not visible. They are not having malnutrition, they are not having stunting, they are not having wasting, but malnutrition is there. That we'll find out when only we see the growth chart. We have to take every 3 months the weight, height, etc. in the growth chart, and we will plot it. And there are percentiles: 50th percentile, 25th percentile, 3rd percentile. So if less than 50th percentile, that means the child is having malnutrition. But when we see the child seems all right. So growth chart is very important. Coming to marasmus, we have seen the marasmus types. So this is one of the malnutrition earlier slide. So what is the present clinical presentation of marasmus? They will have severe wasting of the muscle and the fat, subcutaneous fat. They will have definitely severe growth retardation, and they will not have edema, here changes fatty liver like kwashiorkor, but they are alert but miserable. That means irritable, and they are always demanding for the food. They are hungry. So sometimes marasmus is they will eat, but there will malabsorption, lack of absorption and all, and their faces looks like monkey. So marasmus, you can remember monkey-like faces. This picture, you see this picture, this is a child 3-year-old admitted in the pediatric department, and what is the form of this malnutrition? So this is a marasmic type because there is muscle wasting, says, high, limbs, etc. But buccal pair of fat is retaining. So this child is irritable, all the time crying, demanding for the food. And here there is cannula, IV cannula is on because the child is receiving antibiotic. So there is definitely infection. So infection which leads to marasmic type of the malnutrition. Coming to the wasting or marasmic type, we can grade into grade 1, grade 2, grade 3, grade 4, depending upon the loss of muscle and fat in the area of the body involved. If axilla and groin is involved, then grade 1, buttocks and thigh, grade 2, chest and abdomen, grade 3, and buccal pair of fat, grade 4. So in this side, you see in this side, here there is chest is involved, thigh is a little bit involved, buttocks and all is involved. That means the child is having grade 3 malnutrition. That is chest and abdomen is involved. See, same child, father is holding, she is not able to stand it, not able to sit, and then there are severe wasting. You see the ribs, the exposed here, and then loss of the fat in the buttocks, baggy type, and then wasted all bony. So this is the child suffering from severe wasting, present as a marasmus. Now coming to Kwashiorkor. Kwashiorkor, to understand this, you have to know the cardinal feature. You must have find out this feature in the child who is suffering from Kwashiorkor. There are edema. What side? Pedal edema. Psychomotor changes, that is, they are very dull, not responding to the surrounding, apathetic, and growth retardation. When you check the height, weight, everything will be low, and the muscle wasting. But they will not be visible as a severe wasting because edema is there, swollen fit is there. So these are the 4 cardinal points for the Kwashiorkor. And what are the other associated features? Because of the edema, moon face, changes in the hair, lusterless because of lack of the protein, alopecia, etc. And skin changes because of the lack of the zinc. There will be dermatitis, dyspigmentation, low hemoglobin, that is anemia because of the low protein. And there will be hepatomegaly. As mentioned earlier, liver cells are damaged. So hepatomegaly, fatty liver will be there. And PEM, fatty plaque dermatitis, severe form of dermatitis. The flaky pen, there is erosion of the scales of the skin. And then in addition to this, cardiac failure may be there, the child may be having dehydration, and all the signs of vitamin deficiency like vitamin A, which causes night blindness, corneal ulceration, etc. So this is a picture showing the edema. There is pitting type of edema. The limbs is swollen, and there is dyspigmentation, and this is the flaky pent dermatosis. You will see where it's like painting, but it is flaky. And this is the child showing lusterless, sparse, alopecia. There is lack of easily pluckable, and then there may be fleck signs. That is white part and the brown part. The fleck signs will be there. And this is the eczematous skin excoriated, and this skin, this will be skin will come out because of the Kwashiorkor. So what is the difference? What is the main difference between this uh, marasmus and Kwashiorkor? So the main difference is one is mentally alert in the marasmus, irritable, where it is dull, and apathetic in the Kwashiorkor. Appetite one is good, and here Kwashiorkor poor, and the cardinal sign like edema will present in the Kwashiorkor, and liver enlargement will be there in the Kwashiorkor. Mortality is very high in the Kwashiorkor, and infection is more prone because they have severe form of protein, low protein, and as well as excoriated, scalded skin, where infection, skin is a protective organ, so skin is involved, then chances of infection is very common, and recovery is very slow in the Kwashiorkor type. How to investigate? You should investigate basic investigation like blood sugar to check for blood sugar level low or not, peripheral smear for finding out types of anemia, microcytic hypochromic type, and hemoglobin to find out that severity of the anemia, and urine examination, stool examination to find out infection, and of course chest X-ray and a Mantoux test to find out the tuberculosis. And other tests also can be done if individual cases needs serum protein, electrolytes, and then ICIB. It is a must in when there is a history of exposure to the ICIB. Now, severity of the malnutrition, you know that mild and moderate form and severe acute form. So, important is here mild and moderate, they will not have much problem, but here in the severe acute malnutrition, you must admit the child for the treatment. So, you have to detect. How to detect? WHO has given four criteria. Out of these four criteria, any one is present, then you will say that the child is suffering from severe acute malnutrition, also called SAM. So what are those four criteria? One is weight for height below -3 standard deviation. Standard deviation is given as -1, -2, -3. If it is less than -3, then it is having charm. And or the child is having visible severe wasting, or the presence of bipedal edema, or mid upper arm circumference less than 11.5 centimeter. That means the child is having severe form of malnutrition. WHO has given treatment guideline for the severely malnourished children. So for this treatment, in our pediatric department, you also have nutrition rehabilitation center, that is NRC, where this sort of malnourished, severe form of malnourished are treated. So what are those guidelines? You have 10 steps of guidelines divided into two phases. One is stabilization phase within 1 week, and rehabilitation phase 2 to 6 weeks. So during the stabilization phase, you have to correct hypoglycemia. Hypoglycemia, if blood sugar level is less than 54 milligram per deciliter, then you have to correct it by giving glucose solution. And you have to correct hypothermia if temperature is less than 97, 96.5, then you have to correct it hypothermia by using radiant warmer heater or clothing, etc. And you have to correct dehydration. You have to give replacement and correct electrolyte. If sodium is low, potassium is low, you have to give supplements and start antibiotic to control infection and start micronutrients supplements like vitamin A supplementation, vitamin D supplementation, zinc supplementation, folic acid supplementation, etc. And feeding. Here the child needs calorie based feeding. We have two forms. One is F75 and another one is F100, depending upon the amount of calorie. F75 means 75 calorie in 100 ml of that food. So we will start with F75 low calorie, and then later on shift to the high calorie, that is 100 kilocalorie. By 7 days, the child will correct all those acute problems and then start giving high calorie diet for the catch-up growth and sensory stimulation. That means you have to use play therapy. You have to use vision by audio, video player and all, and then hearing that uh, maybe music in the form of music. So sensory stimulation should be continued throughout the phase, and by 7 days you can start follow up, prepare for the discharge, because during the rehabilitation phase nobody wants to stay in the hospital. So once the stabilization is developed, then in the recovery we can teach the mother, and then we can, if mother is intelligent and then have sufficient manpower or adequate foods, the economics is good, then we can send home during this rehabilitation phase. So a child who is suffering from severe acute malnutrition will need treatment for 6 weeks, that is 1.5 months. So it is not easy. See, you see the child. You have seen the child. Hold, father was holding the child, was not able to stand, was not able to sit, irritable all the time. After treatment, by 10th day, we have taken another photo of the child, same child, and this child is sitting happily eating the food. So after the treatment of all those things, see the beauty of the treatment of the malnutrition. So this child is, we are saving the life of this child, because malnutrition can give rise to mental deterioration, the cognitive function may be affected. So what are the other treatment conditions which associated with malnutrition? We should also consider for that. So if there is vitamin A deficiency, we should give vitamin A. This is to be given if there is signs of vitamin A deficiency like corneal ulceration, widowed spots, history of night blindness, etc. Then we have to give vitamin A on first day, second day, and 14th day of the treatment duration, and depending upon the age. If the child is more than 1 year, there is more than 12 months, you give 2 lakhs international unit. If the child is between 6 months and 12 months, give 1 lakhs international unit. And if the child is less than 6 months, that is 5 months, you give 50,000 international unit. And if there is corneal clouding or ulceration, that means severe form of vitamin A deficiency, then you have to give additional eye care like this antibiotic ointment, chloramphenicol or tetracycline eye drops, because the ulcerated area may be the source of infection. So you give eye drops, antibiotic eye drops for 2 to 3 hours, for 7 to 10 days, every 2 to 3 hours. And also you will give atropine eye drop 1% 3 times daily for 5 days, because the irises should not be stick to the cornea or the underlying structure of the eye. So this will prevent the adhesion of the iris. Dermatosis, when there is, you have seen those pigmentation, scaly skin, eczematous, hyperpigmented, hypopigmented, ulceration, sometimes very exudative, very angry looking skin lesions. Then you have to give zinc deficiency, zinc. This is mainly due to zinc deficiency. So zinc supplementation is very important, and also barrier creams like zinc and castor oil ointment or parathorium jelly or paraffin rose, and omit yeah, especially diapers should be omitted in the perineal area. You have seen that diaper can give rise to irritations. Of course, if there is suspected history of tuberculosis, you must do the Mantoux test when there is contact history. For example, mother or father or grandmother or anybody in the family is suffering from tuberculosis, then you must do Mantoux test and chest X-ray. And if it is positive, you have to give the anti-tubercular drugs according to the national tuberculosis guidelines. It is available in the tubercular health centers. See this child, this is again severe acute malnutrition treated in our ward, and you see the Mantoux reaction. You have to give do tuberculin test, give tuberculin 0.1, 0.01 intradermal, and you see the reactions at the end of the 48 hours. The child is having red indurated area, and then the size is more than 10 millimeter. So if more than 10 millimeter, that means positive. So in such a child who is suffering from malnutrition where immunity is low, still it is expressed as a positive, then you must give anti-tubercular drugs. If you don't treat tuberculosis, the child will not solve the problem of the malnutrition, because tuberculosis may be the one which is causing malnutrition in this child. Now, after treatment, you have given treatment for the child, then you have to see the response. What is the response of the treatment? Good weight gain means if the child is gaining more than 10 gram per kg per day, we will continue same treatment. Moderate weight gain 5 to 10 gram per kg per day. If there is weight gain is not good, then we have to check the intake, how the child is taking, how frequently, whether the infection is controlled or not. And of course, if poor weight gain, that is less than 5 gram per kg per day, then you have to search for the failure of this weight gain. Why? Is there any inadequate feeding by the mother, or is there infection untreated, or hidden infection is there, or some specific nutrients are deficient, like iron deficiency is there, and whether any hidden tuberculosis or HIV is there, or psychological problems due to kwashiorkor, where the child is not interested in the food. Then if that problem is there, in the psychological problem, the child is not taking food, then you may give tube therapy. That means feeding tube are inserted through the nose up to the stomach, and then we will give scheduled feeding every 2 hour, every 3 hour feed. So like that, we have to correct that treatment. We have to complete the treatment of the malnutrition. Coming to prevention, how to prevent malnutrition. This is again very important, because the incidence of malnutrition is not that very rare. It's very common, especially in our country like India. So in the rural area, 46% of the children are suffering from malnutrition, and in the urban area, 33% of the children are suffering from malnutrition. So at the national level, there are so many nutritional supplementation programs. For example, vitamin A supplementation. You are giving vitamin A to the child who is 9 months old onwards after every 6 months till 9 doses to prevent from vitamin A deficiency, which can lead to blindness. So we can prevent blindness because of the lack of the vitamin A. And also you might have heard that iron supplementation programs, that is iron tablets are given in the school children to prevent anemia, which is again one of the main uh, problem in a child suffering from malnutrition. And of course, food fortifications. Food fortifications like some foods, for example, iodine. Iodines are fortified in the salt because iodine deficiency is common. Like that, food fortification at the national level as a national program, it is going on. And of course, at community level, when you see a child suffering from malnutrition, then you need to educate the parents and community as a whole. You have to inform what are the causes of malnutrition, what are the foods containing a good amount of protein, good amount of carbohydrate, a good amount of vitamins, etc. So you have to inform to the person at the community and educate. Educate how to prepare food, how to give, what is the frequency, how much, what is the amount to be given, for how long you have to give, like that. So, for example, a child who is 2 years old, they need 3 to 4 times meal. In addition to that, 2 to 3 times milk or health drink. Like that, you will inform and you will educate at the community level. And of course, immunization, every child should start immunization since birth. So vaccination at birth, what are the vaccines to be given at birth, what are the, for example, BCG is given at birth because we want to prevent tuberculosis, and then so as to prevent from the tuberculosis related malnutrition. So immunization, full immunization of the child should be encouraged. And of course, hygiene practices. Hygiene practices is very important because the food-borne diseases like typhoid, and jaundice, infective hepatitis, etc. They are waterborne diseases. There are so many diseases it is present, can be infected in a child due to lack of hygiene practices. So hand washing with soap and water for 20 seconds should be advised to the parents, as well as the child should be allowed to do these hygiene practices supervised by the mother. And of course, promote exclusive breastfeeding. Why exclusive breastfeeding? Exclusive breastfeeding means breastfeeding milk, breast milk only, not even water, no other foods. So this is to be given till 6 months of age. A child who is 4 months old should receive exclusive breastfeeding because mother's milk is sufficient. Mother's milk is having complete food, balanced food for the child till 6 months. After 6 months, as we mentioned earlier, we should start complementary feeding. That means feed in addition to the breast milk. So this breastfeeding, hygiene practices, immunization, then health education, nutrition supplementation. These, if we do all these preventive measures, then definitely we can bring down to the incidence of the malnutrition. Okay, so this much for today. Thank you. Nuôi đấy ở thế nào?